Okay, good afternoon, good morning, and good evening, everyone. Thank you for joining this WHO EPI-WIN webinar on health systems for health security, an integrated approach, an integrated solution for robust emergency management. Before we begin this webinar, some housekeeping. This webinar is being live streamed on the EPI-WIN YouTube channel. The webinar is being recorded. The recording will be available on our website and sent to all webinar registrants. We invite you all to post your name, location, and organization in the chat box. We would love to hear where you're joining us from. Also, please add any questions you may have to the Q&A box, not the chat, so we can more easily keep track of them. So all the participants will be able to upvote questions in the Q&A box by clicking the thumbs up icon. So if you see questions similar to the ones you want to ask, please do upvote them. Now, before I hand it over to Lena to moderate the webinar, I would like to ask all the participants to fill out the Slido multiple choice questionnaire shared on the screen. So you can access this through the QR code, chat link, or the Slido website. I'll leave the slide open for anyone to view. Over to you, Lena.
Thank you so much. Good day and greetings to everyone. My name is Lena Yu. I'm the Technical Officer in the Evidence and Analytics for Health Security Unit of Health Security Preparedness Department of WHO Emergency Program. I'm the focal point for health system for health security. Thank you for being with us to discuss this important topic. And thank you for your response to this Slido question. Let us take a moment to review the result from Slido. Clearly, we can see that over 40% of colleagues joined today have heard about the health system for security, but don't know the details or don't know how to apply. And thank you for your inputs. These responses set the scene perfectly for our discussion today, and we'll be addressing these key points throughout the webinar. Can I ask my colleague to take off the screen? Thank you so much. Without delay, I would like to invite Dr. Stella Chunggong, Director of Health Security Preparedness Department of WHO, to give the opening remarks. Dr. Stella, please.
Good morning, good afternoon, and good evening to you all. I am pleased to be with you today for this important webinar on the role of health security and health systems in safeguarding our populations. Our efforts began in 2018 when we first started developing the Health Systems for Health Security framework. Just as we're finalizing this document, the COVID-19 pandemic struck, reminding the whole world once again about how important it is to have a strong health system in place that can effectively address health emergencies. And whilst health emergencies keep reminding us about this, the idea is not a new one. Back in 1978, the Alma Ata Declaration set the vision by emphasizing that strong primary healthcare systems are the backbone of health efforts. And this includes our ability to respond to health emergencies. Then, at the turn of the century in 2000, the World Health Organization published the World Health Report, which made it clear that robust health systems are not just beneficial, but essential for effective emergency preparedness and response. And 5 years later, in 2005, the International Health Regulations mandated all states parties to develop the capacities to respond timely and effectively to public health emergencies. The Health Systems for Health Security framework builds on these key global health milestones and foundations that have long recognized that robust health systems, strong primary health care, and universal health coverage are vital for protecting and promoting health and public health, especially during crisis. So what are we looking at in practical terms? And how do we translate these principles into action? Strong health systems capable of surging in response to public health emergencies include several critical components. For example, the health workforce must be robust and well-trained with strategies in place for rapid scale-up during health emergencies and crises. Surveillance systems are vital for early detection and response, and these must be interoperable and integrated with health information systems. Leadership and governance within a health system are also essential, with clear health security plans integrated into national health strategies, comprehensive laws, policies, as well as a coordinated approach that involves all sectors of society. In addition to these, our health systems must have resilient service delivery mechanisms, ensuring the continuity of essential health services and effective case management during emergencies. Medical products and technologies, including immunization strategies and biosafety measures, must be readily available and managed efficiently. Each of these elements, from leadership to logistics to workforce, contributes to a health system's ability to respond swiftly and effectively to public health emergencies. And these must be in place before, not during, a health emergency. That is what health systems for health security is about. We are currently working on how to integrate these components as part of our planning process so that countries can consider these elements whilst developing their national action plans for health security. I would like to thank our colleagues within WHO, our regional offices, and our country office colleagues, as well as our partners who have been collaborating and supporting this area of work. I look forward to the insightful discussions from our panel members that will follow after me, and to the collaborative efforts that will emerge after today's meeting. I thank you.
Thank you, Dr. Chungong, for guiding us through the development of health system for health security and highlights its key practical applications with concrete examples. Following these critical words, we will have a presentation from Dr. Nirmal Kandel, Head of Evidence and Analytics for Health Security Unit at the WHO headquarters. Dr. Kandel will explain the health system for health security framework and tell us how health system for health security supports the effective management of health emergencies. Dr. Kandel will then chair the panel and invite our esteemed panelists who will share their experience and insights. They are Dr. Alaka Singh, WHO representative in Sri Lanka, Dr. Sridharan, Deputy Director General, Planning, Ministry of Health, Sri Lanka, Dr. Mark Ho, Lead, Pandemic Preparedness, Asia Center for Health Security. With that, I hand over the floor to Dr. Kandel.
Thank you, Lina, and thank you, Dr. Stella Chungong, our director, for making time for this webinar. And I'd like to thank also EPI-WIN team for hosting us. And thank you for setting the scene with the Slido questions. Many of you have heard but don't know the details, so we are here to go through it. I have 3 slides to explain, basically carrying from why we need health system for health security, what is it about, and how we are going to operationalize and when. So let's start with the why. Why health system for health security is important. As Dr. Stella mentioned in opening remarks, the many lessons that we have learned from COVID-19 and in relation with the health systems which are required to manage the emergencies. So if you recall from the COVID-19 scenarios, there's a lot of hospitals, a lot of healthcare workers who got infected because of poor infection prevention and control. There's a shortage of oxygens. There's a source of requires increased source of healthcare workers. and not matching those demands, we face a lot of challenges and a lot of incidents and case fatality rate. WHO did a survey also in many countries, and 90% of countries reported disruption of essential health services. And we cannot strengthen all these things during emergency. And this is why health system for health security is important. I would like to take a quote from our Director General. Quote, COVID-19 is not just a global health security, it is a vivid demonstration of the fact that there is no health security without resilient health systems or without addressing the social, economic, commercial, and environmental determinants of health. We also highlight the role of other sectors in this framework. Next slide. Now let's move, what is health system for health security? So it brings all the sectors, including health systems, together with the health security components together. I would like to start with one example, infection prevention of control. If we had IPC in place in all over the world during the pandemic, we wouldn't have lost so many healthcare workers, and we may not have lost so many people also. So, but at the same time, we cannot strengthen infection prevention and control during emergencies. This needs to be in place as part of the routine public health systems from primary health care to tertiary care. So this is where we need to identify those foundational health system elements that need to be in place in order to ensure health security of the population. So if you look at, there is a health security related to IHR core capacities. We have a health system building blocks, 6 building blocks, each contributes to, there are foundational elements of health system building blocks for health security capabilities also, and also the contribution of other sectors. For instance, IPC, if we have good health system for facilities, as well as IPC required for the emergencies, but imagine if we don't have a good quality water and sanitation systems, then there will be challenge. So there's a huge contribution from the other sectors as well. In order to achieve the goal of resilient health system, responsive with the social protections, ensuring health security, so on and so forth. Next slide, please. So how to operationalize health system for health security framework? We come up with looking at the National Health Policy Strategic and Plans, which we call NHSPs. In some countries, it's 5 years, some countries, it's 10 years. And it is a simple methodology. We review these NHSPs and relevant documents to look at functional or foundational elements of the health system that are required for the health security. We conduct the desk review, we do the in-country consultation, and then we put the recommendation to update the NHSP in the next iteration. When to do it? Ideally during the planning reviewing cycle of the NHSP, and it can also link with to contribute to the desk review and country consultation of the National Action Plan for Health Security. Our team and collectively all of us were working on how to integrate National Action Plan for Health Security and NHSP, because country has NHSP as a major founding and budgeted plan, which is implemented and regularly updated. To guide this process, we have a WHO benchmarks for strengthening health emergency capacities, which the updated version identified the foundational elements of the health system and other sectors in the document as well. This is my last slide. The next slide is just showing the other areas of work that we are carrying out. There are case studies. If you have a good case examples, please share with us in ehs@who.int. So with that, I conclude my presentation, and with the moderator permission, I would like to move to the panel, STEAM panel who are present here today. And to set the scene for the panel, the Sri Lanka is the first country which has implemented, followed all the process that we explained earlier. And it's good to hear from our colleagues from Sri Lanka Ministry of Health, as well as WHO country office. Our representative, Dr. Alaka Singh, is here. So Dr. Alaka, with your support, Sri Lanka became the first country implemented the health system for a health security framework. Can you briefly describe WHO's efforts in supporting Sri Lanka for strengthening emergency preparedness, and tell us why and how to effectively implement the health system for health security framework when countries have limited resources? If you also can add what was the momentum to implement HSforHS in Sri Lanka. Over to you, Dr. Alaka.
Thank you very much, and a very good evening to everybody from Colombo. Before I get into the main question here, please do allow me to give you a very quick background on Sri Lanka. Sri Lanka has been outstanding in its health achievements. Sri Lanka implemented primary healthcare even before Health for All in the 1920s and has actually achieved basic indicators that are well above its income group. This, in fact, was the foundation of Sri Lanka's initial response to COVID, including the immunization effort, the sound immunization network. So it was really 2021 when we had a terrible third wave of COVID. Unfortunately, it was superimposed by the worst economic crisis the country faced. So by April 2022, Sri Lanka had to suspend all non-emergency procedures in its hospitals because it was, well, just to put it very simply, short of foreign exchange and simply didn't have the medicines or the medical supplies. Now, very clearly, what this brought up front is the country has one health system. We cannot have a health systems for emergencies that we pull out of the closet when we are faced with an emergency. And that's why the importance of health system strengthening for health security. Just to give you an idea as to the extent of the crisis, in the September of 2022, year-on-year food inflation was as high as 96%. That's just to give you an example. So Sri Lanka has been facing a poly crisis. From our perspective in WHO, of course, our business is health. And how do we help Sri Lanka secure, sustain, and preserve its exemplary primary healthcare approach to make sure that we also safeguard the achievements? Now, in terms of health, the health systems is really based on the principles of UHC. We have public investment in public health for equitable and quality care. In the crisis, how do we preserve it? So last November, we had reached out to headquarters to help us really implement this health systems for health security framework. What we have found in its implementation, that it's a very structured approach that looks at strengthening health systems for resilience on the one hand, and is aligned to and it's reinforced emergency efforts like IHR and HEPR. So it really brings all stakeholders together across all sectors. Nirmal has just shown us a slide on that, but we found that it worked very effectively. We did use it to analyze the National Health Strategy for 2016 to 2025. It came at a very opportune moment. Dr. Sridharan, I'm sure, will talk more about it, but we are currently now with MOH drafting the next 10-year policy and plan. So it's a very good opportunity then to actually integrate HSforHS into the next 10-year plan, which really is the plan for recovery, the change in policy for recovery. What we did find overall, if I may share some of our findings, is that the Sri Lanka National Health Strategic Plan, as designed currently, has a wide range of health security related elements. However, these are not very well embedded. There is the need to prioritize the integration of these elements within the plan, including IHR coordination, biosafety, access and provision of essential health services during a crisis, the interventions for management of chemical and radiation events. All of these need to be a little more prominent in our plan. Again, we have one plan for the country, for the one health system. Also, and I'm sure this is across all countries, Sri Lanka has multiple acts, multiple parliamentary decisions, the National Action Plan for Health Security, the National Disaster Management Plan. What is lacking is the interconnectivity, so that these are reinforcing. They're not just aligned, they're also reinforcing. We can start very simply with cross-references, for example, but we really need to use the next 10-year plan to bring all of this together. Now, so far as the areas of health systems are concerned, 3 areas for consideration have been brought up using the HSforHS framework, which is service delivery, strengthening the first level of care, human resources, particularly the capacity to respond to emergencies and the entire range of emergencies, and of course, financing. In Sri Lanka, we are aware that primary healthcare and universal health coverage has been based on domestic resources. Now, given the economic crisis, given the financial restrictions, we do need to make sure that that is preserved, that health security for emergencies is included in the essentials or standard benefit package. And that's what we are supporting to design. There's no question that a well-prepared health system really contributes to mitigating the impact of health emergencies, saving lives, and reducing economic loss. The important thing about HSforHS is also that we were able to use it as a platform to bring our partners together. WHO, with its technical assistance, is collaborating with World Bank on the one hand, that's coming in with significant financing for recovery in Sri Lanka, as well as the ADB, but also other UN partners, FAO, for example, and of course our usual partners, UNICEF and UNFPA. Finally, something that perhaps Sri Lanka needs to look a little more carefully at is the huge potential of technology. We are trying to tie this into HSforHS, including things like digital surveillance for AMR going forward. But this is one area that we need to look at very carefully across the board. So that's really been, Nirmal, in a nutshell, our experience. Really found the framework very useful, including in the poly crisis. So we're looking at the context of preparing the health system to make sure that we are able to respond to multiple emergencies in a context where we're very keen to preserve what Sri Lanka has achieved. In fact, it's been a model for other less developed countries. A lot can be done for health, even though we are not economically advanced. And going forward, we see the opportunity of the next 10-year plan to make sure that we have a comprehensive and aligned and a reinforcing approach to HSforHS. I'll stop there. Thank you.
Thank you, Dr. Alaka, for your nice, great, insightful speech. And I'm sure participants will benefit from your experience and looking forward to implement health system for health security according to their context. I would like to invite now Dr. Sridharan, who was very instrumental and led the whole process of health system for health security operationalizing in Sri Lanka, from reviewing, consultation, and also of accepting our various invitations to share this experience. This is the third one for him. And thank you so much, Dr. Sridharan. So I have a question for you to share with us. So what are the major findings and recommendations and challenges in implementing health system for health security in Sri Lanka? Over to you, Dr. Sridharan.
Thank you, and good evening to you all. First of all, I wish to thank inviting Ministry of Health for this webinar. And before answering your question, I'll briefly, in a nutshell, I'll tell about Sri Lanka health system. The health system in Sri Lanka operates in a decentralized manner, and services are provided in public health facilities as free of charge at the point of care. We have 1,164 hospitals, including primary care, secondary care, and tertiary care, out of which 62 hospitals are under, only 62 hospitals are under line ministry. Those are the tertiary care hospitals and the teaching hospitals. All the preventive health, MOH, medical officers of health, are under provincial councils, decentralized. And even though it is decentralized, the health system for health security, all 9 provinces work as one family. So, like in one of the slides, it was mentioned about this during the COVID situation. So, when one province had more than the expected COVID patients, we were able to mobilize HR, human resource from other resources from the adjacent provinces. So other provinces also helped the adjacent neighbors for this COVID-19. So it is like a one family. And the Ministry of Health in Sri Lanka has been actively working on a periodic health sector policies. And we have this 2015 to 2000, as Dr. Alaka Singh told, 2016 to 2025. The current plan will end in 2025, and we plan to start development of the next policy in 2025. So that is for 2026 to 2035, and definitely we'll be including HSforHS in the next plan. Also, we have done the policy review, 2016-2025 health policy review we have done, midterm evaluation is done, and it is published, and it is in the Ministry of Health website. And we have done with WHO technical support, we have done this strategic direction for the sustainable financing. I must thank WHO for this, and we are in the process of, with the assistance of WHO, conduct the trend analysis. So, okay. And with the support of WHO, the Ministry of Health recently conducted policy review for using HSforHS framework 2. And the implementation started with a desk review by WHO on the National Health Strategic Framework and other documents, including JEE assessment, in consultation and discussion with the WHO regional and country office. We were then engaged to the on-site workshops with key stakeholders that involves in the planning and implementation of NHSP, as well as key persons from emergency preparedness and IHR. Through the review, we noticed that there are some gaps in incorporation health security components in NHSP, and a need to systematically incorporate health systems for health security elements and establish cross-referencing and interconnections among policies, strategies, and plans in the next NHSP, that is 2026-2035, to ensure coherence and resource optimization. Let me take human resource workforce an example, because you all know we have NHSP as 4 volumes: preventive, curative, rehabilitation, and human administration, human resource. If you take health administration, human resource for health as a distinct domain, and volume 4 has been dedicated to HRH. The NHSP incorporates HRS programs, including human resource development, human resource management, and a dedicated directorate of training and education. Based on this plan, we have established a human resource coordination unit at the Ministry of Health now. The review noticed the gaps of human workforce development and enhancing targeting emergency. Therefore, we developed and agreed and recommendation to consider critical areas such as workforce projection, production, recruitment, emergency deployment, professional development, measures to motivate and retain personnel, and the enhancement and surge capacities. And we have, through the Ministry of Health, has requested Postgraduate Institute of Medicine to train consultants in emergency medicine. So we have about 25 emergency physicians working throughout the country. These changes and recommendations will facilitate a more agile health service delivery that can adapt to emergency demands without compromising the quality of ongoing health services. It fundamentally shifts how we allocate resources during crisis, ensuring that essential services are maintained. Then, and if you take one of the challenges we face, major challenges, is we trained health personnel, these medical officers, doctors, and nurses in emergency management, but there's a trend of migrating the HR. So we have, even though they are migrating, we are still didn't give up. We are still keep on training the emergency physicians. Health systems and health security operates in silos in our countries. The implementation of HSforHS framework brings the stakeholders of NHSP and the key person in emergency preparedness together to discuss the holistic approach. Still, I see the need for continuous close the gap and build a bridge. Thank you.
Thank you, Dr. Sri, for sharing your experience on the implementation of health system for health security, and looking forward to work with you and WHO team for the next updating of the National Strategic Plan 2026 to 2035. With that, I would like to now invite Professor Mark Ho. Before giving floor to him and putting the question, I just want to acknowledge that he is one of the key player for the development of this framework when he was working with us in WHO headquarters. So Mark, thank you for your valuable support on this topic. Now, speaking of the policy and different contexts, please share your insight on the role of health system for health security in policy and system adaptations required to meet the specific needs and challenges of various regions and support pandemic preparedness. Some of you might be aware of this framework as mentioned in the Slido, and talk from the Mark will definitely address those. We know the framework, but we don't know the details and how to use for the policy. Over to you, Mark.
Thank you very much, Namal. It's really been some time since we started work on the Health Systems for Health Security framework, and that was in 2018. At the time, we started off with a more conceptual model, including the building blocks for health systems and the international health regulations capacities. And there we worked with partners like Leeds University to back it up with robust policy analysis and case studies to illustrate what this is about. The intent was to bring together the narratives of universal health coverage, which was more closely tied to the work on health systems, with health security and emergency preparedness. And at times, looking at these two concepts, it feels like you're dealing with two different languages. But we've come quite a long way, and I congratulate the colleagues from Sri Lanka for implementing the framework in such a successful and effective way in the country. Now, we've all lived through a pandemic that has lasted for much longer than most people had expected. It was so long that there were other smaller health emergencies that happened along the way. Natural disasters, surges in other endemic diseases after we reopened countries, and emerging pathogens like Mpox. This period actually has provided far more real-life examples across the world of how this framework is important and relevant today. Countries that invested in strong and resilient health systems seem to fare better, not only in managing the main crisis, but also reducing illness and deaths from other diseases due to disruptions in essential health services. This is especially those that were versatile enough to swing their health systems to meet changing demands. So many countries, including my country, Singapore, saw firsthand the importance of this framework during and after COVID-19. We may not have directly applied the framework, but we can see on reflection how it was used in many ways. Manpower remains the essential backbone of our response, whether it be public health activities such as contact tracing or the delivery of medical care. The way that we organize manpower has also changed with time. Some hospitals have adopted flexible shifts for nurses to cope with manpower shortages. There are also new models of care emerging. Some rely more on primary care doctors and the expansion of telemedicine. These help to ensure that limited hospital beds in a crisis can be used for patients who need it the most. We also have data from electronic medical records and the testing of wastewater that are useful for surveillance and risk assessment. And moving forward, there is now a push towards big data and artificial intelligence, and it remains to be seen how we do this. The world also saw how important medical products are, whether it is vaccines or antivirus medications, and yet we have global challenges around equitable access. These decisions could not have been made, and nor the activities carried out, without robust leadership and financing, such as how Sri Lanka had talked about their Ministry of Health coming in to help, both before and during the pandemic. We need to ensure that the lessons learned from COVID-19 are not forgotten, and that will always be adequate financing for the strengthening of these health systems. And without any of these building blocks, it would not have been possible for any of our countries to respond effectively to a pandemic like COVID. Now, Singapore is a small country, and we are part of a wider Southeast Asia region and a wider global community. The strengthening of health systems in other countries is just as important as the local level. It is thus in all our countries' interest to support each other in building stronger health systems that are better able to prevent, detect, and respond to future health emergencies and other outbreaks. So in closing, the Health Systems for Health Security Framework and Implementation approach is a useful way to focus our attention on how investments in health systems can have wide-ranging benefits. Sometimes health security investments appear to be about buying insurance or about preparing for a storm. However, the framework explains why the same health system components that are so essential on a day-to-day basis can be leveraged for emergency response. They are integrated into a broader health initiative, be it disease prevention or chronic health management programs. And if each of our countries can use the framework the way, for example, that Sri Lanka has done so, as a way to foster policy dialogue, we can truly make each of our communities, our regions, and the world a better prepared world to face the next health threats. Thank you, and I pass back to Nirmal and the team.
Thank you, Mark, for your insightful speech and sharing the experience. And I would like to thank all the panelists once again. And now we move to the question and answer session. And please put your questions in a Q&A box, not in the chat box. And we have already received a few questions, and we will start. I'll start with the response to first question myself, but before that, I would like to take the second question, probably by Dr. Sridharan, because there is one interesting question, and I think from your conflict, the previous conflict, it might be useful to give your experience as well. The question is, I would like to ask the panel about how countries can recover and move forward after wars, as they consider one of the major public health emergency and affect the health security on the long term. So, Dr. Sridharan, when preparing this question, I'll take another question, which is on considering the experience of COVID-19 pandemic, potentially as H5N1 epidemic, dengue fever, monkeypox, ongoing worldwide diseases. We still use references, international health regulation. What is the current legal basis for international response to public health emergencies of international concern? Could you please further elaboration? So the legal basis is IHR 2005, and it's clearly mentioned to detect, report, and notify, and provide coordinated response. Based on the lessons learned from various emergencies and COVID-19 pandemic, as you are aware, there is ongoing discussion on the targeted amendment of the international health regulations as well as the pandemic agreement. So we are waiting for the decisions during this World Health Assembly for further guidance from the member states on how to move forward on this topic. So with that one, I would like to request Dr. Sridharan to share some examples from Sri Lanka's past experience. Over to you, Dr. Sridharan.
Yeah. Dr. Nirmal, should I take the question on financing before Dr. Sridharan comes in? Will that be all right?
Fantastic, no problem.
Yeah.
Go ahead.
Put the question as well, please. Can we see that? Okay, the question is, you mentioned the country is not economically advanced. What were the financial frameworks and other resources that enabled the system to tackle the challenge? Indeed, Sri Lanka was a middle-income country, sort of middle-income country, and because of COVID and the economic impact of COVID and the financial crisis, it's now it slid down to a low middle-income country. Now, let's not forget, when Sri Lanka set up its primary healthcare, it really focused on a cost-effective approach to health. Immunization, maternal and child health, all these are very cost-effective responses. Of course, it needs government commitment, but there was a careful selection of what would bring really good impact in terms of health indicators and the kind of investment that the government made. And through the years, there's equitable access to quality care. However, out-of-pocket expenditure in Sri Lanka is indeed 50%, but it's one of the very few countries in the world, certainly perhaps the only one I know, where this is not regressive. So about 70 to 80% of those who are spending out of pocket are really the top 20 income group. They are self-selecting out of the public health system. So in that way, it's very efficient. Now, why is this time very critical for Sri Lanka? One, like any country that's done well on health indicators and on its health outcomes, the challenge going forward is NCDs, and it could become high-cost individual care. Number two is an aging population. And this is why the next 10-year plan is very important, because in 10 years, we expect about 20% of the population to be 20 to 25% of the population to be over 60, and that's what Sri Lanka categorizes as aging. There have been a lot of reports discussing Sri Lanka getting old before getting rich. So far, we're okay. And this is why this is a very important point in time to rethink primary healthcare in Sri Lanka. That's what WHO is doing with the Ministry of Health. It's about improving cross-programmatic efficiency. It's about improving primary healthcare. So services that can be provided at the primary level in a cost-effective way are actually being placed. Now, the other issue that we've been discussing in Sri Lanka is also from the demand side. Sri Lanka has a very literate population, and there is the potential to use health literacy very effectively as well to improve efficiency in demand. So far, we've been fine with public investment in public health because the focus has been on a cost-effective response. But going forward, where we both have constraints on the budget and the GDP on the one hand, and the challenge of NCDs and an aging population, possibly future emergencies, we need to be careful. And this is why the HSforHS framework is very important. As expenditures are going to very likely increase, we need to make sure that we also are prepared for potential increase in demand on relatively limited resources in case of an emergency. Thank you.
Yeah, thank you. During war, that is, the war was from 1983 to 2009, almost 26 years. Okay, but health was not compromised. That is the main the government never compromised for health. And even during the immunization days, there's a ceasefire from both parties. Okay. And government of Sri Lanka sent medicines and HR to the war-prone areas, even though it is detached from the mainland of the country. So we sent medicines and HR to maintain the health in the war-prone areas also. So after the war, we were able to quickly recover because of the national, the one plan we had for the health system. And as Dr. Alaka Singh told, we started this primary care in 1926. So this was throughout the country, it was like that. So we didn't deviate from the original plan. So we were asked to actually the voice in northern and the eastern provinces. Immediately we with government of Sri Lanka funds, also from the foreign funds, we were able to renovate all the hospitals. If there's no hospital, even build new hospitals, secondary care hospitals and primary care hospitals, and send human resources immediately to restore the health of this country, even the war-prone area. So this government of Sri Lanka never compromised health, even though it is war-prone areas or not. So that is the main advantages of Sri Lankan health system. And you know that in every 3.5 kilometers radius, there's a government health institution. Still, even in the war-prone areas those days, we were maintaining that one. The same plan was implemented, policy and plan was implemented throughout the country. Even there was a 26 years war. So that is my brief answer for this question. Any more to answer this?
But I just want to emphasize something that Dr. Sridharan has said. You know, we talk about political commitment. I think it's been really on display. It's been demonstrated very strongly in Sri Lanka. The political commitment to health and indeed education is quite remarkable. And that's what saw through the war years. That's what's seen through COVID. And I'm sure, I always make the point that Sri Lanka has led in peace times, and I'm sure Sri Lanka will lead in terms of recovery as well. It will be a model for recovery post-COVID, economic crisis, poly crisis. It really is down to the political commitment. And we see that on display.
Yes, thank you, Dr. Alaka. Now, in addition, what Dr. Alaka Singh told, she spoke about the elderly population. We are expecting that by 2035, 25% of the Sri Lankan population will be elderly population. So if the economists say that the globally, not only this increasing elderly population, the climate change and new diseases also. So the next plan, our next plan will focus on these 3 areas too: climate change, new diseases, and increasing elderly population. Thank you.
No, thank you, Dr. Sridharan and Dr. Alaka. Sri Lanka always set an example. In a public health school, Sri Lanka, state of Kerala, and Cuba are the best example of health achievements in a low resource setting. We don't need a lot of money. It's all about political commitment and management. We will take one last question, and this question I would like to request Mark to take on. So what are the main pillars you recommend to strengthening in order to have a robust emergency management system in fragile setting? Over to you, Mark. Sorry to put you on spot.
Thanks, Nirmal. Well, I mean, I must say that I'm very impressed by what the Sri Lanka colleagues have shared, and they have also shared their experience on pillars that were very essential for them during periods where things were difficult in terms of a poly crisis as well. I think one of the things that comes across when I look at the different pillars is that the manpower pillar is essential in comparison to all the pillars. We do need all the pillars to be there for a robust health system. But if we don't have manpower that's trained, that is able to respond, that's flexible, that is able to address the different challenges, then everything else that may be there, if you have the technologies and you have the information and the governance and the financing, it'll be very difficult to implement on the ground. And I think we have seen this in COVID, we've seen this in multiple emergencies, whether it be in the higher income, but especially in the lower and fragile settings. One of the things that I always remember was the role of community health workers, you know, in some of the countries in Asia, where when the health systems of some of these countries, the formal tertiary hospitals were overwhelmed, it was the community health workers that stepped up into that role. And that's where some of the resilience of health systems really comes from. So I think a short answer, Nirmal, to your question, if you ask me, even though it's a difficult choice to make across the pillars, I would say that manpower is really something we need to invest in and pay attention to. Back to you, Nirmal.
No, thank you. And I totally agree on that one. The World Bank Lancet paper on human capital is the one which always emphasizes invest on the human capital. And Sri Lanka is another good example who made the education system publicly free. And that's why the literacy rate and applied knowledge on the ground, not only health in other sectors also is very good. So human capital is the key. With that, this panel and moderated question and session is over, and I give the floor back to our moderator, Lena.
Thank you, Dr. Kendall, and distinguished panelists and everyone who participated in this engaging discussion. From today's webinar, we can draw several key conclusions. Effective emergency response requires a strong health system and other sector support, adaptable to evolving needs and crises. Invest in health system and other sectors to meet the challenge of health security is critical, taking the lessons learned from the past health emergencies, including the COVID-19 pandemic. We need to embrace a whole of government and all of society approach to ensure long-term investment in health system for health security. Health system for security is a bridge, is an integrated solution to align different plans to the national health strategy, policy, and plans. In the meantime, reinforce the preparedness for health emergency. Thank you so much for your participation, and I want to invite Dr. Stella Chungkung to close the session. Dr. Stella, please.
Thank you so much, dear participants, dear panelists, colleagues from our country offices, from our regional offices, from headquarters, our partners who have accompanied us on this incredible journey that has been built throughout the lessons that we've learned from different health emergencies, including the COVID pandemic. We have learned that we must do something about the critical gaps that were identified throughout these health emergencies. We saw how systems could not surge to meet the demands that were put on them by a health emergency. We saw how the workforce in countries, and Dr. Hu spoke about that, and many of you did, could not meet the demands that was expected of them, whether in terms of flexibility, whether in terms of numbers, whether in terms of skills and competencies, to be able to deal with the emergencies. We saw how it was very difficult for many countries to continue providing essential services, how many people died from other diseases, heart attacks, diabetic complications, road accidents, and they were not able to be taken care of because the systems could not meet the demands because the resources were sucked away by the health emergencies. We saw how these resources could not be moved to where they were most needed, whether it was geographically or in terms of accessibility of populations to services. And this must never happen again. We each have a responsibility to make and contribute towards building health systems that are resilient and that can take and absorb the shocks that are given to them by small emergencies, but also by the big ones. And as many people often say, you get better by doing something repeatedly. So let's start with the small things and we'll get better over time. And when the pandemic comes, when the big things happen, we will be extremely well-versed in dealing with them. So thank you once more. And I can only encourage every participant and every member state to try and see how best they can operationalize this framework. Thank you, Sri Lanka. Thank you, our WR, for this amazing experience and amazing journey. I'm sure many of our participants will reach out to you to learn more of what you did right and how to build on the success that you have shown in your country. Thank you.
Okay. So as we've come to the end of our allotted time, I'll just wrap up by again saying thank you to all our panelists from the Sri Lanka team, Dr. Alaka, Dr. Sridharan, Dr. Sapumal, and then also Professor Mark, and also the WHO colleagues, Dr. Stella, Nadret, Kai, Nirmal, Lina, and Anton. And of course, Supriya from the EPI-WIN team who works to make all this possible. And finally, thank you to all the participants for joining and submitting your questions. We have shared a link to the WhatsApp group so that you can join if you wish to continue the conversation with each other. And if you want to stay updated on the future EPI-WIN webinars, recording, and presentations, please do subscribe to our mailing list. And let me just share my screen as well. Please do share with the EPI-WIN team how you use this information from the webinar. We would love to hear from you. So if you have any photos, links, or documents, please feel free to share that with us. And finally, please do join us for the next EPI-WIN webinar that we will be having on Thursday, 23rd of May. And all the registrations will be sent through email. Thank you again, and see you next time.